Hello, 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 everybody. It is Thursday. Time for 10 question Thursday. I think based on my insights, I'm going to change the 10 questions to once a week on Thursdays starting next week. So there's more, it seems like more people are available on Thursdays versus Tuesdays. So we're going to just do it on Thursdays. My name is Cheryl. I'm a registered nurse with 20 years of experience in this cardiovascular surgical ICU. I work at one of the largest hospitals in Washington, D.C. And I have been a nurse. Actually, I started out as an LPN, then I became an RN, and I've done several things in long-term care and acute care. So, if you want to connect with me, you can use my IG bio, and there are several links in there. DM me if you like. We're going to get started. All right, so the first question is, the most accurate method of obtaining heart rate from an ECG strip with a regular rhythm is to A, count the number of large boxes between two P waves and then divide that into 300. B, count the number of R to R intervals in 6 seconds and multiply that by 10. And C, count the number of small boxes between two R waves and then divide that by number into 1500. And D, count the number of QRS complexes in 6 seconds and multiply that by 10. All right, so the answer is actually count the number of boxes, which is C, between two R waves and then divide that by that number into 1500. Heart rate can be obtained from the ECG strip several methods. The most accurate is, if the rhythm is regular, is to count the number of small boxes. One small box is 0.04 seconds between the two R waves, and then divide that number into 1500. In a 1 minute strip, there are 1500 boxes of 0.04 second intervals. Another way you can do it is to count the number of large boxes between the two R waves and then divide that number into 300. Using P waves in this method gives the atrial rate, not the heart rate. When the patient's rhythm is irregular, a useful method is to count the number of R to R intervals in 6 seconds and multiply that number by 10. In this method, oops, sorry about that. Knocking my tripod over already. The R to R intervals are counted, not the QRS complexes, to avoid overestimating the heart rate. So there you have it. 2 ways to do it. All right, our second question is, a 55-year-old male patient presents to the emergency department complaining of intense right leg pain that is not relieved by rest. He states that the pain has started approximately 4 months ago, but that it only hurt when he was using his legs and was relieved as soon as he would sit and rest. He reports that his pain increased yesterday while exercising and that it is now hurting him at rest as well. He states the pain is severe and constant since yesterday. It starts in his lower thigh and runs down to the back of his calf to his ankle and the top of his foot, and is not aggravated by sudden position changes. He describes it as a throbbing pain and denies any pain in his left leg. He denies any recent trauma to his leg. Based on the patient's description, all of the following diagnoses are likely, except is the key word: A, peripheral artery disease or PAD. B, peripheral venous disease or PVD, also known as peripheral vascular disease. C, sciatica. And D, deep vein thrombosis. So what do you think it is not, is the question. The answer is sciatica. So sciatica is this patient could have like PVD or PAD or DVT based on the symptoms. His description of the pain doesn't fit with a diagnosis of sciatica since it does not radiate from the back or his buttocks and is not aggravated by sudden position changes. Obtaining further history of present illness and past medical history and some diagnostic testing is needed to reveal the exact diagnosis. So they might need to do like ultrasounds of the lower extremity, for example, and if it's really, really bad, they can even do an angiogram. All right, next question. The patient with the following conditions is not a good candidate for initiation of thrombolytic therapy. And the first answer is head trauma 2 months ago, left bundle branch block, recent myocardial infarction, history of GI. So the options for this question: head trauma 2 months ago, left bundle branch block, recent MI, and history of GI bleed 6 months ago. The correct answer is head trauma 2 months ago. Absolute contraindication to thrombolytic therapy includes stroke or head trauma within 6 months, active internal bleeding, history of intracranial bleeding, cerebral neoplasm, or other intracranial pathology, known allergy to the chosen drug. Alternatives to thrombolytic therapy include interventional therapies done via catheters such as balloon angioplasty, PTCA, or with or without stenting, and then thrombectomy or removing the clot itself. Left bundle branch block and recent MI are both considered indications for thrombolytic therapy. A GI bleed within 2 months, not 6, is relative contraindication. Not absolute. Okay, question number 4. Which of the following findings is associated with cardiac tamponade? Pulsus paradoxus is A, widened pulse pressure, B, heightened awareness, C, increased cardiac output, D. What do you think? Okay. So the correct answer is pulsus paradoxus. Cardiac tamponade is compression of the heart that occurs when blood or fluids builds up in the space between the heart muscle and the covering or the sac of the heart. This compromises the cardiac function and the cardiac output. Signs and symptoms of this medical emergency include tachycardia, shortness of breath, anxiety, and decreased level of consciousness. Pulsus paradoxus. Pulsus paradoxus is a fall in the systolic blood pressure during the inspiratory phase. It has to be a fall of more than 10 millimeters of mercury during the inspiratory phase. And then equalization pulmonary pressures. So all the CVPs, the PAD, the PAOP are all within 2 to 3 millimeters of mercury of each other. Which is accompanied by muffled heart tones and decreased blood pressure and cardiac output. Now, if you have somebody in cardiac post-op and you see this, there is a high chance that you will see the bleeding or the drainage from the chest tube or the mediastinal tubes. You will see that just suddenly stop sometimes. Okay. It's a medical emergency, so when you see it, you call somebody right away. You have no time. And actually, one of my colleagues was telling me the other day that she had a patient. That patient was fine. They were extubated. They were fine. And then she was within, I think, the 24-hour period post-op. And she just became anxious. And she was saying how she was really feeling really anxious for no reason. And that when the nurse saw the CVP, that equalization of the pulmonary pressures, and she also saw the tachycardia and the hypotension, so she ended up going up on her norepinephrine a lot more. And so she called the provider right away, and when they put the bedside probe on her to look at her heart, they found she had tamponaded. So they ended up opening up her chest right there that particular day, sedating her, of course, and all that. Not wide awake. In the management of the patient with acute respiratory distress syndrome, ARDS, we see a lot of ARDS now because of COVID. The most appropriate ventilator settings include tidal volumes of 8 milliliters per kg, 6 millimeters per kg, 4 millimeters per kg, and 2 millimeters per kg. Which one do you think it is? Now, I'm not really strong with this ventilator stuff. I know the basic stuff. But the answer is 6 milliliters per kg. The goal in ARDS management is to achieve and maintain adequate oxygenation while avoiding barotrauma. Numerous studies have determined the most appropriate ventilator settings to ensure lung protection consist of using small tidal volumes, that's why it's 6 milliliters per kg, to prevent volutrauma, and higher PEEP levels to recruit the alveoli. In addition, the FiO2 should be set to achieve the goal of a PaO2 of 60 millimeters of mercury or greater. Okay, number 6. Indications for an intra-aortic balloon pump or IABP use include all of the following except. When you're taking questions, you got to read. When it says except, you choose the wrong answer. Okay, so the indications include all the following except A, moderate to severe aortic insufficiency, B, unstable angina, C, cardiogenic shock, D, inadequate peripheral perfusion. The answer is A, moderate to severe aortic insufficiency. Okay. The balloon pump therapy works on the principle of counterpulsation. Gas moves back and forth from the balloon pump console to the IABP, that's helium, causing an inflation, a deflation of the balloon. Inflation occurs during ventricular diastole. Okay, increasing the intra-aortic pressure and blood flow to the coronary arteries. Deflation occurs immediately before ventricular systole, decreasing intra-aortic pressure. The goal of this treatment is to reduce assisted systolic pressure and augment diastolic pressures. Common indications for a balloon pump therapy includes angina, refractory to medical therapy. Also hard to treat angina. Left ventricular failure, cardiogenic shock, which is very bad, and failure to wean from CBP after cardiac surgery, or coronary pulmonary bypass after cardiac surgery. Symptoms necessitating the need for balloon therapy include symptoms of cardiogenic shock like tachycardia, systolic blood pressure greater than 90, MAP greater than 70, cardiac index 2.2 to 2.5, PaO2 pressure of less than 18, decreased oxygenation, unstable angina, inadequate peripheral perfusion, and decreased urine output. Contraindications include moderate to severe aortic insufficiency and aortic aneurysms. Okay, moving on to the next question. The severe hypoxemia present in acute respiratory distress syndrome, ARDS, can be attributed to A, increased lung compliance, B, shunting as a result of collapsed alveoli. C, a fluid shift from the interstitial areas into the pulmonary vasculature. And D, haline membrane formation over the alveoli. A, B, C, D. Which one do you think it is? It is B, shunting as a result of the collapsed alveoli. I can't even talk. What's wrong with me? I think I worked too much today. That's the problem. Nurse worked too much. Probably didn't eat, right? Anyways, here is the rationale. The development of acute respiratory distress syndrome, ARDS, may either be as a result of direct injury to the alveolar capillary membrane, which is a primary cause, or indirect damage from chemical mediators in response to systemic disorders, which are secondary causes, as you have with COVID, the COVID infection, for example. ARDS is characterized by excessive alveolar capillary membrane permeability, interstitial edema, fluid shifts or shunts into the interstitial spaces of the lungs, and diffuse alveolar injury, collapse over alveoli. This is very tongue twisting for me today. I don't know what the deal is. This alveolar and interstitial edema, microatelectasis, and VQ mismatching leads to severe hypoxemia and poor lung compliance or stiff lungs. Try not to get ARDS. All right, next question is, a nurse caring for a 32-year-old patient who was struck by a motorcycle, or the nurse is caring for a 32-year-old patient who was struck by a motorcycle. He sustained multiple injuries, including a fractured pelvis. You have noted that he is hypovolemic or is in hypovolemic shock. Which of the following treatments would be contraindicated in the management of this patient's hypovolemic shock? A, administration of normal saline. B, administration of isotonic crystalloid solutions. C, administration of vasopressors to maintain blood pressure. Or D, administration of colloid solutions. Well, it's a lack of volume. So what you're going to do is you have to fix the volume problem before anything else. So C is the right answer, which means administration of vasopressors to maintain blood pressure shouldn't be, it's contraindicated. And here is the rationale. The administration of vasopressors to maintain blood pressure would be contraindicated in management of this patient's hypovolemic shock. Treatment with vasopressors should only be considered when hypotension is resistant to volume resuscitation. So you have to give them the volume first, try to resuscitate them that way because they are hypovolemic. So you want to replace the volume first. And if that's not working, then you add the vasopressors. The goal of the therapy and management of hypovolemic shock is to identify the source and stop the bleeding if possible, and replace circulating volume, which can be accomplished with one of the following in large rapid boluses. You can give the isotonic crystalloid solutions like LR, normal saline, and you can do blood, colloid solutions, plasma or blood. They have this rapid transfusion device that you can give several liters, several units of blood and blood products in minutes to somebody who is really actively bleeding and is losing blood too fast. Control of further bleeding is essential and may require surgical intervention. Direct pressure is appropriate to obvious wound sites. Type and cross-match for blood type and administer blood as needed for hypovolemic shock. Sometimes you don't have time to type and cross-match somebody, and you have to you just don't have that time. So sometimes you might have to get on cross-matched blood. I have had that experience firsthand, so it's rare, but it does happen. All right. 2 more to go. A nurse is assisting during a routine cardiac catheterization and notes that the patient's extremity feels cool to the touch. Furthermore, the nurse notes that the extremity is losing color and upon auscultation notes a thready, weak pulse in the same extremity. Which of the following conditions has a patient most likely developed? An infection, a CVA, peripheral thromboembolism, or pulmonary edema? Couldn't be an infection, not that quick. CVA, CVA normally doesn't cause any coolness to a specific extremity. Pulmonary edema, you usually have like tachycardia or tachypnea with that. So the correct answer is peripheral thromboembolism, or PE. No. During cardiac cath, a number of complications may occur, including peripheral thromboembolism or embolus to the extremity. In this scenario, manifestations include the pain, pallor, weak pulse or pulselessness in the extreme cases, paresthesias, and paralysis. The extremity also may be cool to the touch. Interventions for this condition include continuing heparin or other anticoagulants therapy to assist in breaking the clot, in addition to possible thrombolytic therapy directly into the clot using a tracking catheter. If these fail, surgical intervention may be necessary. So as I was saying, a stroke, also known as a CVA, can be caused by a thromboembolism but presents with a neurological symptom. You would need to monitor the patient for signs and symptoms of neurological compromise, such as speech patterns, orientation, and vision. An infection would not immediately be seen. The symptoms of infection would include erythema, inflammation, heat, or exudate at the catheter site. You would need to monitor the patient's temperature trend for that. And in pulmonary edema, you would need to elevate the patient's head of bed to 30 degrees and administer diuretics as necessary. Okay, last question. Let's see. All right. If a chest tube is indicated for removal of pleural fluid, the critical care nurse knows that the tube should be inserted at the 7th intercostal space, mid-axillary line is A. B. Okay, the first answer is 7th intercostal space, mid-axillary line. Second intercostal space, mid-clavicular line. 5th intercostal space, mid-axillary line, or 4th intercostal space, mid-clavicular line. The answer is 5th intercostal space, mid-axillary line. So always mid-axillary, not mid-clavicular. Mid-clavicular is here. Mid-axillary is here. Chest tubes are commonly indicated in the critically ill to remove air, blood, or fluid from the pleural space or the mediastinum. Pleural tube insertion sites vary depending on the type of drainage to be removed. For pleural fluid drainage, a tube should be inserted into the 5th or 6th ICS at the mid-axillary line. For air removal, the tube should be inserted into the 2nd ICS at the mid-clavicular line. That's here for air. Air and then fluid. Mediastinal tubes are placed during surgery, exiting from the mediastinum below the xiphoid process somewhere here. Okay, so all my questions today got them from Pocket Prep. You can get a free trial from them. I am not being paid for this, by the way. This is just free information for you, resource-wise. And I found it very helpful in reviewing for my CCRN, for example. There's a link to it on the AACN, which is American Association of Critical Care Nurses website. I am going to update one of my links so that you can get a link in my bio so that you can get access to it after I'm done here. I should have done that before, but I just thought about it, so I will link that to you. All right, if you have any questions about TQT or 10 question Thursday now, you can DM me, you can email me. My links are in the bio. So I will see you next Thursday. So I'm not going to do 10 question Tuesday. I'm just going to do 10 question Thursday going forward for you guys, okay? And look out for a blog post that is coming. I'm also working on some things that are going to be downloadable. Have a good evening. Hi, Corona. I'm just ending. All right, see you guys next week. I'm gonna post it if anybody misses the whole thing. I'm gonna post it in a few minutes on my IG. Okay. See you then. Have a good evening. Bye.